This talk is about understanding the importance of preoperative TKR X-ray. As we all know, TKR is an effective surgery that can help relieve pain and restore function in patients with severe osteoarthritis. One of the most important factors in the long-term outcome, long-term success of this operation is to do thorough preoperative planning before a TKR. What are the goals of preoperative imaging? Is to detect the severity of the disease, whether the disease is whether it is early arthritis or advanced arthritis, to assess the relevant anatomy. So on these X-rays, we can calculate various angles. We can assess the deformity to determine the level of level and orientation of bony cuts. Sizing of the components can be done on preoperative X-rays, and we can detect bone deficiencies. So what are the standard X-rays one has to order before a TKR? These are long length films or scanogram, AP view both in standing and supine position, the lateral view in 30 degrees of knee flexion, and Merchant's or skyline view to detect patellofemoral arthritis. So what are the long length films or a scanogram? As we know, accurate limb alignment is the most important factor for long-term outcome of a successful TKA. These are the standard AP view of the extremities. They are taken from hip joints to the ankle joints. So these scanograms, they help us in calculation of mechanical axis of the limb and as well as pharma angles, that is femoral, anatomical and mechanical angle axis. So what is the mechanical alignment? John Insall, he originally described the use of mechanical alignment in total knee arthroplasty. It is a straight line passing from head of the femur through the center of the knee and ankle joint. It is very important to achieve mechanical alignment during the surgery. So that can be done by making proximal and distal femoral cuts perpendicular to the mechanical axis of the femur and tibia. So this is a scanogram where we can see the mechanical alignment of the lower extremity. In a normal knee, it passes through the center of the knee. In case of varus or valgus, the mechanical alignment will either be medial or lateral to the center of the knee joint. So tibiofemoral angle can be calculated, that is between the anatomical axis of the femur and tibia. So normally it is 6 plus minus 1 degree. The hip knee ankle angle can be calculated between the mechanical axis of the femur and tibia, which is 0 or 180 degrees. So here we can see the varus and the valgus knees. In the center, we can see that in a normal knee, the mechanical alignment is through the center. In a varus knee, the center of the knee joint is lateral to the mechanical axis. In a valgus knee, the center of the knee is medial to the mechanical axis. So if you have a scanogram, we can calculate varus or valgus deformities. So that is the angle formed between the mechanical axis of the femur and the mechanical axis of the tibia. Even if you don't have a scanogram, but if you have a knee X-ray which includes, which has ankle joint also, so we can calculate these angles by drawing anatomical axis of the femur and mechanical axis of the tibia, but you just have to add or subtract the normal valgus angle to it. The next is AP radiograph of the knee. The AP X-rays are taken both in standing as well as in supine position. So standing X-rays are important to identify the severity of the arthritis, to classify arthritis. Supine position AP views are required for proper planning, that is templating before the surgery, and to detect whether the deformity is correctable or not. So on a standard AP view, we see the medial and lateral joint spacing, the articular surfaces of the medial and lateral joint compartments. One can measure both intra-articular as well as extra-articular angular deformity, bony deficiencies. As in a lower X-ray, we can, on looking at the X-ray, we know that there is a medial bony defect. So one can be well prepared before the surgery that this patient is going to need either a bone graft or a cement augment or maybe a constrained prosthesis. We can see osteophytes on an AP view, classically the medial osteophytes. So in majority of the varus deformities, the knee is stiff. When you do a valgus stretch, the knee is very stiff, either because of a shortened MCL or because of a tight MCL. So these medial osteophytes play an important role in causing the tenting of the MCL. So intraoperatively, if one takes out these medial osteophytes, it causes somewhat, it relaxes the MCL and opens up the medial gap. AP views also tell us about the amount of subluxation of femur over tibia, either a medial subluxation or the posterior subluxation, whether the need for constrained prosthesis is there or not. We can calculate the angle and the level of bone cuts. Implant sizing can be done using a template. Both the femur and the tibial implants can be sized, and we can get a rough estimate of the size of the implant. In patients who are very short stature, small bones, or tall patients, sometimes we may need to order an implant which are not commonly used during TKR. So arthritis is classified on an AP view using Kellgren-Lawrence system, which is graded from normal to grade 4. The normal means no radiological findings of arthritis, and grade 4 consisting of severe joint space narrowing, sclerosis of the bone ends, and marked osteophytes. The next is lateral radiograph of the knee, that is taken in 30 degrees of knee flexion. So the patellar height should be assessed on this view by calculating insult-salivity ratio. If the ratio is above 1.2, it is patella alta. If it is less than 0.8, it is patella baja. So especially patella baja is important. If the patient preoperatively has a tight knee along with patella baja, so that will be a difficult case during the surgery when one has to subluxate the patella. So maybe a more extensile approach will be required in such cases. So loose bodies and osteophytes can be seen both posteriorly in the tibia as well as the femur. Suppose if there is a large posterior tibial osteophytes or a cupping of the proximal tibia on lateral view, then one has to decide whether to start with the tibia or the femur. In these cases, the tibial subluxation is very difficult. So one can start with preparing femur first, followed by tibia. We can calculate tibial slope on a lateral view, anterior trochlear surface. We can look for calcified blood vessels. If the blood vessels are calcified on a lateral view, it is better to do a TKR without the tourniquet. Implant sizing can be done both femur and tibia on a lateral view. So next is the calculation of posterior condylar offset ratio. So nowadays this is being studied extensively just to detect whether this is important in determining post-operative knee flexion and flexibility of the knee. So PCOR is basically, if you look, it is a ratio of D upon B. So where the D is the distance calculated from posterior condylar surface to the posterior cortex of the femur, and B is distance between posterior condylar surface to the anterior cortex of the femur. And PCO, it is mainly posterior condylar offset. So Merchant's view or skyline view, it helps to assess the patellofemoral alignment, calculation of the sulcus angle. If you see patellar tilt or subluxation on this view, that may alert the surgeon for lateral release during the surgery. So can we predict patellar maltracking? Yes, by looking at the shape on a skyline view, one can decide whether the patella is going to maltrack during surgery. So Weiberg has classified patella into three types according to the shape, where type 3 being vertical orientation of the medial offset, and this is the type which is more likely to go into maltracking during the surgery. So finally, to summarize, meticulous preoperative planning is required for successful outcome, to avoid surprises on the operation table, to save time and energy, and to reduce complication rate. These are references. Thank you very much.